Welcome to Anti-Diabetic Drugs Part 2. So I'll be discussing a drug called as your Metformin. Metformin is a very commonly used drug. So when you're in second year, when you go to clinics, when you take family history and you take drug history, so you encounter many diabetic patients telling metformin as their drug. So it's used as essentially used as a first line drug in treatment of diabetes. When you're an intern, you've been taught how to give metformin, what is the dose of metformin, and what are the side effects of metformin. Again, when you're a resident or a PG or even a practicing doctor, so we all encounter metformin. Hence, detailed knowledge of metformin is extremely important from both clinical perspective of view as well as your entrance point of view. In entrance, they ask many questions on diabetes, mostly on anti-diabetic drugs, and usually one or two questions will be on metformin. So hence it is very important to learn all the characteristic features and all the special features of metformin. So, and personally, it's a very favorite topic of mine to discuss in anti-diabetic drugs. So we'll dive deep into it of the mysteries of metformin. So, as I've highlighted, metformin happens to be euglycemic agent. So when I'm talking about other drugs, for example, if I talk about DPP-4 inhibitors, for example, if I talk about DPP-4 inhibitors or GLP-1 agonist, or even if I talk about your sulfonylureas, they all essentially cause your hypoglycemia. They cause your hypoglycemia. This is one of the special feature of metformin. It does not cause hypoglycemia, it causes euglycemia. Hence it's called as euglycemic. Only at toxic doses of metformin does it cause hypoglycemia. Otherwise, it is a euglycemic agent. And this topic or this sentence of mine has been asked many times in your entrance exam. Hence, it's very important to know this property of metformin. So, metformin belongs to a class of drug called as biguanides. Another drug in this class is fenformin. Both of these drugs were discovered in 1950s and has been used since then. But the thing is, since the chance of lactic acidosis, since there is a serious side effect of lactic acidosis with the use of fenformin, it has been banned in India in 2003. So clinically, the only drug which has been used now is metformin. Okay. So now we'll come to the mechanism of action of metformin. So another peculiar feature of metformin is it requires insulin for its action to take place. Other drugs cause the release of insulin, whereas metformin requires insulin for its action. And since it requires insulin for its action, hence it is not useful in type 1 beer. Okay. And other peculiar feature is other drugs act on beta cells of pancreas or it acts through GI tract, decreasing the absorption of glucose. Whereas your metformin, it acts on something called as your AMP dependent protein kinase. Extremely important again. It's been asked many times in your entrance exams. It acts on your AMP dependent protein kinase and it decreases your hepatic gluconeogenesis. Hepatic gluconeogenesis. It essentially means it is decreasing your hepatic glucose output. It is decreasing hepatic gluconeogenesis or it is decreasing hepatic glucose output. This is one of the major mechanism of action of metformin. So this is the property which makes it euglycemic. It is not hypoglycemic, it's basically euglycemic. Other few features through which it acts is it basically increases your insulin mediated glucose uptake. Okay, it acts on AMP dependent protein kinase, it decreases hepatic gluconeogenesis, it increases insulin mediated glucose uptake. Okay, this is one of the second property. And the third feature through which it acts is it interferes with mitochondrial respiratory chain and it decreases your fatty acid oxidation. So these are your three important features which makes metformin different from other anti-diabetic drugs. First point is it requires insulin for its mechanism of action. Hence, it cannot be used in case of type 1 DM. Okay, it acts through AMP dependent protein kinase and basically decreases your hepatic glucose output and decreases your hepatic gluconeogenesis. It increases your insulin mediated glucose uptake. Also, it interferes with the mitochondrial respiratory chain by decreasing your fatty acid oxidation. So these are very important features of metformin, and this is how mechanism action. This is how metformin actually acts. Another important feature which has been noted with the use of metformin is it improves lipid profile. This can be a potential question which can be asked in a NEET as well as INI. So when used in a diabetic patient, it improves your lipid profile. Okay, this is one of the features. It's very extremely important. Then come into pharmacokinetics. Nothing much to remember. Only 2 points needs to be remembered. One thing is it has good oral absorption, which is fine, not a problem because metformin is given orally. So of course it has good oral absorption. The second point is it is contraindicated in renal failure. This is a question which has been asked many times both in your INI as well as NEET exam. So what is happening is metformin is excreted. Metformin is excreted via your kidneys. So it is basically excreted via your kidneys unchanged. Hence what happens is the clearance of metformin approximately is equal to your GFR. Of course, it's excreted unchanged through kidneys. Hence, clearance of metformin is approximately equal to GFR. So what happens in renal failure? Renal failure, what happens is there is increase in the accumulation of metformin, which is obviously it is toxic. Hence, it is contraindicated in case of renal failure. So if a diabetic patient comes with a CKD or if there is any renal failure, definitely you shouldn't give metformin. It's counterproductive, it's quite bad. So this is a question which has been asked repeatedly, and it's an important point to remember clinically also. Now coming to something side effects. Side effects, there are many side effects of metformin. The commonly experienced side effects by patients are weight loss, which is being seen in many patients. Unlike your sulfonylureas, which causes your weight gain of 1 to 3 kgs, metformin causes weight loss. It's a very important side effect. And then you have your diarrhea or even GI upset, you can tell. So this also has been seen in many patients. Diarrhea as well as GI upset is also a very common side effect. And there's also feeling of tiredness which is seen in patients using metformin. Along with these 3 side effects, you have the most important side effects which has been asked in your entrance exam repeatedly again. So first one is your B12 deficiency. They may even give you a clinical scenario in INI set or even NEET PG. So for example, a 60-year-old patient, diabetic patient, is been using metformin for close to 10 years and he develops your tingling sensation or knuckle hyperpigmentation. So you, of course, seeing the clinical scenario, you have to get a catch on it that metformin has been the cause of B12 deficiency. That's how it goes. So B12 deficiency, it affects your absorption of B12 and causes B12 deficiency. And one of the rare side effects which is seen with metformin happens to be lactic acidosis. This also has been asked. Both of these questions has been asked in your NEET as well as INI. These are PYQs which are extremely important. And even it's quite important clinically. Then the most important part of the discussion. What makes metformin so special compared to other drugs, and why is it considered as a first line, why is it used as a first line drug compared to others? So first one, I've been specifying it from the beginning. It is euglycemic, not hypoglycemic. That's one of the special features which I've been telling you from the beginning. Second one is, of course, I've already told you, promotes weight loss. It promotes weight loss, okay? So if an obese patient with diabetes comes to you, you start with metformin because it promotes weight loss as well as it helps in your insulin resistance. The third most important feature is it does not accelerate beta cell failure. So this is quite tough to understand. When I talk about your sulfonylureas, it basically acts on your beta cells. It acts on your beta cells and causes the insulin release. Essentially, sulfonylureas depend on your beta cells to cause insulin release. So over the time, when you're continuously using sulfonylureas, your beta cells also get exhausted. There is basically beta cell failure which takes place over a long period of time when you use sulfonylurea. Hence, sulfonylurea or any other drug which promotes your insulin release over a long period of time causes your beta cell failure. Since metformin does not act through beta cells, it does not accelerate beta cell failure, which is extremely important to remember. Then, when we are discussing about diabetes mellitus, we always tell there is microvascular complications as well as macrovascular complications. This is extremely important. This is the cause of death in most of the patients, which in diabetics. So studies have shown that metformin, it has a potential to prevent all these micro as well as macrovascular complications. How good is it in preventing? We still don't know, but of course the research have been made and studies have shown that it does slightly improve with the micro as well as macrovascular complications. The other thing that waiting physician notes in a diabetic patient is, after starting a drug, is what's the decrease in HbA1c value or what is the improvement in HbA1c value. Metformin, when a patient has been started with metformin, he usually has a decrease of HbA1c by 0.8 to 1.2%. It's one of the great feature of the drug. So compared to other anti-diabetics, it has shown to reduce HbA1c by a value of 0.8 to 1.2%. This also is one of the special characteristic feature which has been shown by metformin. And the sixth feature is it is even used in your PCOS. PCOS is diagnosed by your Rotterdam criteria. And in PCOS with insulin resistance, metformin is used. So these are your 6 special features. I'll repeat it again. Extremely important for exam as well as clinical point of view. It's a euglycemic drug. It promotes weight loss. It does not accelerate beta cell failure. And it has the potential to prevent both your microvascular as well as macrovascular complications and reduces your HbA1c by 0.8 to 0.2%. This point is somewhat, I cannot tell it reduces HbA1c in all patients, but in majority of patients when started with metformin with good dietary control, it has shown to reduce HbA1c by 0.8 to 1.2%. That's how it goes. Okay, 1.2%, it's 1.2. And of course it is also used in case of PCOS with insulin resistance. So these are special features which has been seen by metformin. So I'll summarize metformin once again because it's extremely important. It's a first line of drug. It's euglycemic agent that it belongs to a class of drug called as biguanides. Okay, it acts through AMP dependent protein kinase. It decreases hepatic gluconeogenesis, insulin mediated glucose uptake. It basically increases, and also it decreases the fatty acid oxidation. And it is known to improve lipid profile in diabetics. Since metformin is excreted through kidney, clearance of metformin is approximately equal to GFR, hence it's contraindicated in renal failure. It's repeatedly asked in your NEET as well as INI. And most common side effects are weight loss, diarrhea and tiredness. And other two important are B12 deficiency as well as lactic acidosis. This is quite rare to occur. And these are the special 6 features of insulin. Now the other question is, how do you use insulin? What is the dose of insulin? When I'm teaching other anti-diabetic drugs, I don't go into the dose and how do you start an anti-diabetic. Since it is metformin, we should make an exception. We should learn it properly. So imagine a 60-year-old patient comes who is diabetic, type 2. He's been diagnosed as type 2 DM. So what is the first line of drug you start? First line of drug. His fasting blood sugar is around 160. Okay, his HbA1c is around 7.5. Very simple. How do you start treatment and how do you proceed? The first line of drug here is your metformin. What is the dose of metformin? Initially it is started with 500 mg. Okay. Another important thing which I forgot to mention is, if HbA1c is more than 9.5, okay, it's better for you to start insulin. Okay. If HbA1c is above 9.5, it's better to start with insulin. If it is less than 9.5, the first drug, which is metformin, is quite commonly used. Okay, you start with metformin 500 mg. You check for the glycemic control. If it's not glycemic control, okay, then if it's not improving, then you can step up the dose to 500 mg BD. Okay, even 500 mg TID can be given. So maximum dose of metformin which can be given happens to be 2 grams daily. Okay, so this is the dose. So very simple. A 60-year-old diabetic comes with type 2 DM. His FBS is 160 and HbA1c is basically 7.5. The first line drug which is used happens to be metformin 500 mg. Okay, so after giving metformin 500 mg, after a few weeks you check for the glycemic control. If it is controlled, you continue with the drug. If it's controlled, you can continue with the drug. If it's not controlled, you increase the dose to 500 mg BD and you can go up to 500 mg TID. and maximum dose of metformin which can be given daily happens to be around 2 grams of metformin. Okay, if the patient is still not in good glycemic control, then you can add off few drugs such as sulfonylurea, so you can even add up DPP4 inhibitors. Yeah, DPP4 inhibitors can be given. And even after 3 drugs, the patient is not being controlled, then you can go for your insulin. That's how you essentially treat diabetes mellitus. And of course, before checking or before treating a diabetic patient, you should perform a series of investigations. That is your FBS, your PPBS, your HbA1c. Okay, you can even perform. It's very essential to perform your lipid profile. Okay, your fundus examination to be done. Baseline ECG to be done. Okay, then you can go for your renal function test, your albumin creatinine ratio. So these are essential investigations that has to be performed before starting drugs in your type 2 DM patients. So that's it about your metformin.